Hello, and welcome to today's session, the first of a two-part series on shared decision making, the journey with gene therapy. My name is Dr. Courtney Thornburg, and I'm the medical director of the Hemophilia and Thrombosis Treatment Center at Rady Children's Hospital, San Diego. And I'm joined today by Brian O'Mahony, who is the chief executive of the Irish Hemophilia Society and former president of both the World Federation of Hemophilia and European Hemophilia Consortium. This education is supported by independent educational grants from BioMarin, CSL Behring, Pfizer, and Spark Therapeutics. Before we get started, I would like to mention that your questions are encouraged. If you have any questions for us, please make sure you type them in the chat or comment box so we may address them during today's session. So, Brian, it's nice to see you. Thanks
Hi, Courtney. Nice to see you.
for yes, for being part of this with me. And today we are talking about shared decision making for gene therapy. And this is a process where patients and clinicians come together to discuss treatment options in the context of the patient's values and preferences. And I'm wondering if you could share your thoughts about why this is important now in the current hemophilia treatment era and what the benefits are.
Well, I think the hemophilia treatment has moved on exponentially in the last 10 years. Right from the 70s to about 2014, we had coagulation factor concentrates where one unit of one was the same as one unit of another. And then we had extended half-life factor concentrates, several EHLs, and then we had the first mimetic, and now we have gene therapy. So the therapeutic area has become much more complex, and therefore the decision making process has to change alongside that. And I think, especially for gene, it's shared decision making should be the way that decisions are made between the doctor and patient for every hemophilia therapy. But for gene therapy, I believe it has to be mandatory. It has to be mandatory because this is a one off, irreversible therapy. Unlike any other hemophilia therapy, if you do not get the outcome that you want, you can't redose, you can't change the dose, you can't take more. So I think it's a one-off irreversible therapy. So it's a major decision and should be done on a fully informed basis and based on several discussions between the clinician and the patient.
Yeah. Yeah, so I'm hearing, yeah, it's not just a one-time visit in the doctor's office. And how do you think patients can prepare for shared decision making? Are you aware of any tools or other educational content?
I think a lot of the patient organizations have developed content. So we have to be aware that if you take the hemophilia patient population in any country or region, you're going to get people with PhDs, you're going to get people who didn't finish high school, you're going to have people with various levels of not just education and comprehension, but also various levels of interest. And some people will be very interested, others will not. So I think patient organizations have been developing a range of educational tools, booklets, videos, infographics, social media posts that they can use to get a certain level of information to patients. And I think one of the key roles of the patient organizations is to help prepare the patients for that interaction in the STM process with their doctors and clinical teams. And then I think the clinicians will have to have their own information, their own tools, their own resources. But I think it's really important that the patient organizations and clinicians work synergistically on this, that we work collaboratively, and that we're not giving different messages and confusing people all the time in relation to this.
Yeah. Yeah, that's a great point. And as a clinician, this is something that's totally new and that I've been now learning about for the past several years. So I think, it puts the clinician and the patient on a little bit more level, playing field. Although I think often, the physicians or other clinicians have easier access to the resources. So I think you're right in the role of the patient community-based organizations to help people find the right resources. And I like to mention the World Federation of Hemophilia has a shared decision making tool that's now online on their website that takes people who are learning about hemophilia treatments through sort of a journey in terms of thinking about where they are now with their current treatment, if they're achieving their goals or their other goals that they like to achieve, and then a process to learn about the different treatment options, and then sort of putting it all together in the end. So then we'll have a resource to take to their clinician. So I don't know
Well,
if
it's
you've
good.
looked at that tool or if.
Absolutely. I
Mm,
really like it. And in fact, we used it last weekend at one of our
yeah,
conferences with about 50 members. We went through the tool with them. I had somebody there playing the role of somebody who wanted to change therapy. And so we went through his rationale. So it's a really nice tool. It gets people started down the
yeah,
road of looking at shared decision making. And as you say, the clinicians have more access to resources, but a lot of those resources are very scientifically based. The level of comprehension required to look at the the nomenclature is fairly massive in some cases. So I think
yeah,
we need that collaboration and cooperation. And the other point you made is, of course, it's not a single visit. So if the person with hemophilia starts engaging with the centre in a shared decision making process around gene therapy, it's not going to be one visit or meeting, right? It's going to be several, at least, maybe multiple over a period of time. So I guess we also need to realize that, and I'd be interested in your view on this. Do you have the time in your clinical practice to do that STM process with patients? And how long would you estimate it would take with an average patient to do an STM process on gene therapy?
right. Now that's a great question. And I think the treatment centers are going to need to adapt and find new models because, at this point, certainly we have all of our patients who come in for their annual comprehensive visits. But, they're meeting with up to, 6 to 8 people. So that's already, a several hour visit. And so, I mean, I always make a point at those visits to um, talk about new therapies, but I think we really need separate visits where, at least starting hour long to talk about um, the what gene therapy is, and really the pros and cons, the efficacy, safety issues, logistics, going through the whole process, and that will just be a starting point. I think I'm a pediatric hematologist, so I think about now when I have sort of the first couple of visits with the parents, and depending on whether or not there's a family history, particularly if there's not, and now I'm talking about 4 to 5 different treatment options. And so I can't get through it all in one visit. And so I think the treatment centers can think about, okay, which clinicians should be involved. And so it may be the physician, nurse practitioner. I think part of it is the social worker, making sure patients are prepared in terms of psychosocial impact, and if they have the right support system. And so, and then gauging where the patients are. They may know right away, no, I'm not ready for this. Let's sort of table it and come back, or be ready to set up further visits. Um, and I know, now we do have more options with telemedicine where we can do virtual visits. So, for these ongoing discussions, I mean, we need face-to-face conversations, but we don't necessarily have to be in the same room sitting next to each other.
And certainly, we found in the past when talking about gene therapy clinical trials to people who were theoretically interested that we did group meetings. So rather
Yeah,
than the clinician speaking with just one patient, we would have 10 to 20 in the room. And what we found was that added great richness to the conversation because somebody would ask a question that somebody else hadn't thought of and would only have thought of after going home.
yeah,
So actually, they got more benefit from those group meetings.
yeah. No, that's a great point. I've done that in the past with some other um, decisions, and heard about some centers who are doing that now. And you're right. I think with anything new, sometimes you don't know what you should be asking. So having that other input.
And of course,
Mhm,
yeah, I think a very, very important aspect is, define where are you, what other treatment options does the individual have? So putting
yeah,
gene therapy as a possibility in the context of the other treatments available to them. I mean,
yeah,
the context would be entirely different in the USA and India, for example, in terms of other therapeutic options. So they need to look at that, and they need to look at, I think we're moving towards a time, and it's a good time to be in, where rather than saying, this is the treatment I can give you, now what are you able to do with your life? You
right.
can ask, what would you reasonably like to be able to do with your life, and now which treatment option would best meet your needs in that regard.
Yeah.
It's
Yeah, I
turning it on
to
its
yeah.
head.
Yeah. No, I totally agree because as a clinician, I don't see my role as, deciding for the patient or being prescriptive, but really being able to, give the right information transparently. And so, yeah, there can be comparison between different treatment options. And, that comparison has been changing over the years as we have, different therapies.
So, can I ask you, Courtney, about how do you communicate the mechanism of action of gene therapy to your patients?
Yeah. Yeah, so I think the the most common thing that I use is sort of the package delivery with the box and the genetic information getting boxed up in the vector, and then being delivered as a one-time infusion, and the package going to the liver and then being unboxed, and so the contents can be um, used, and in the factor then can be made and be effective. And then of course you have to recycle the package, uh, and I do explain that then once you've had your delivery and the liver is making the factor, there is variability in terms of response. And if you know and you can't get a second package of and so it's a little bit different than now we can go on Amazon or other delivery services and just order multiple packages and get the result. But in this case, you have the one time based on the current science.
I agree, and one of the techniques we used during a workshop about 2 years ago with our members was we went through gene therapy with them. We explained what it was not. We talked about the knowns and unknowns
Yeah,
and the areas where you couldn't be sure of durability, variability, and so on. And then at the end, there were a stack of sealed envelopes on the table, and each person randomly took an envelope. That was their individual outcome. So there was no way of predicting which envelope you got or what was in the envelope. And then that was a good way of showing as well, you need to understand the overall concept. At the same time, you need to be aware of the variability that can occur.
yeah. So I think that's part of sort of managing the expectations, where you need to be able to accept some degree of
Yeah,
uncertainty. And uh, and so I think part of that discussion is setting up what, as you said, what's known and unknown. And if patients are going to move forward with gene therapy, then they understand the different options, and then also what might happen if they don't have the a response or lose response over time.
I agree. And there was a Canadian survey carried out last year by the patient organization, which showed that a significant proportion of those surveyed wanted certainty about the factor expression they were going to
Yeah,
get. And that's really, you can't get that. You can't get that certainty. So I think it's making people aware. It's all about setting and managing your expectations. I think
yeah,
is the crucial thing here.
yeah.
Can I ask you then about patient eligibility and screening?
Sure. Yeah. So I mean, now we're moving from, clinical trials, although there are still ongoing clinical trials, but into commercially available products. So in that case, then the eligibility will be based on what's in the label at this point. And we have to look at each specific product, the one for hemophilia A and the one for hemophilia B. But at this point, the basic eligibility is that you're an adult, so 18 and older, and have basically severe hemophilia, and that you do not have a history of factor 8 or 9 inhibitors. Um, and so there's sort of that basic eligibility. And then there's eligibility to sort of ensure safety and efficacy. And that really revolves around the liver and the liver health, because the liver is what needs to produce the factor. And so there is then testing in terms from laboratory and imaging to ensure that there's not any ongoing or active liver disease. And then I would say, sort of, then the commitment as an eligibility criteria to the ongoing follow up, so that it's critically important afterwards to have more frequent visits than most people are used to check to see how much factor is being produced, what the liver function is looking like, and then also commitment to maintaining healthy liver by avoiding alcohol and medications, and maybe even certain other lifestyles that could um, cause liver disease.
Yeah, I think it's really important that the patient understands the level of monitoring and commitment required, especially in the first year, even with licensed gene therapy. I had one elderly gentleman who called me and said that he was quite interested in gene therapy. When I asked him why, he said he had to go to the centre once a year and he'd like to get rid of that visit. Now, I pointed out to him that he's going to, he's going to be at the centre a lot more often than he's ever been in the past in the first year post gene therapy, because of the requirement for regular follow up. And I think this is all it's very logical, but I think it should never come as a surprise to the patient. They need to understand that beforehand.
Right. Yeah, and I think it's important then in terms of timing, and in terms of when one might decide to have gene therapy, if you've just started, university, or started a new job, or have other very serious obligations, then that might not be the best time to have gene therapy. Uh, so something to think about there.
Do you see an ideal age or stage of life to have hemophilia gene therapy at?
That's a great question. I think in if you just think about health, then I would say, the earlier you can get it, the better, because then you preserve your joints, and if you anticipate, a very long effect, then you get the most benefit for the longest period of time. However, in that, young adults, sort of 18 to 26, there are a lot of changes going on. I think maturity levels are still evolving in terms of that commitment. Um, but I think it's really individual, because uh, it's going to depend on life circumstances.
I fully agree. We've talked about this as well, and we would have people in every age group interested, and
Yeah,
in people in every age group not interested. And I
yeah,
think you might get the younger men who like the idea of being freed from regular intravenous or subcutaneous therapy and being able to travel, maybe and have career options. You'd have slightly older guys who want to focus on their career and they don't want to be dealing with hemophilia too often.
yeah,
You'd have people with young kids, young families who want to be very active with their children. You might have older adults with some pre-existing joint damage who see this as a way of increasing their factor expression level and
yeah.
more protection. So I think you're absolutely right. There's no target age. There's no ideal population here. It is very individual.
Yeah, and I think I've learned as a clinician that I don't want to go into conversations or recommendations with preconceived notions, even based on sociodemographics or
Yeah.
disease state, or anything. It needs to be open to everybody who's potentially eligible.
So what about the route of administration?
Yes. So, so it's intravenous. It's a one-time infusion over several hours, and uh, I think in terms of one of the important educational points then is what that infusion day looks like, because it is it is going to be more than a couple of hours in terms of the person coming into the infusion center or treatment center, wherever it's going to be administered. The Because then I think that's sort of like the go point in terms of then when the pharmacies preparing the product, needing to ensure good IV access with one or two IVs. Um, Having all the staff prepared for an infusion, and able to react to any infusion reactions, and then the actual infusion, um, which is IV infusion, so it's not something magical, but it is in terms of what's being delivered, and then some monitoring period post infusion, and then making sure that there's then the follow up in place in terms of knowing who to call, when the next visit is, or testing. But one time IV infusion.
Yeah, I think the it surprises people sometimes. They think it has to be a very complex process. It's relatively simple. It is a one-off IV infusion taking an hour or two. As you say, it takes most of the day once you have all the screening bloods and things done. But it's a fairly simple process in itself. I think it's the follow-up afterwards that's quite complex and has to be
Yeah.
done properly. Um, and in fact, I think in Germany, my understanding is that the patient spends overnight in a hospital, not because of
Okay.
a clinical requirement, but if you do that, there's no value added tax on the gene therapy, so it actually saves them a high proportion of the cost. But in general,
Oh, okay.
it's an outpatient procedure taking a couple of hours, much simpler than most procedures people with hemophilia would have done. Um, so if we get on to patient expectations, and I think this is a huge area
Yeah.
in terms of looking at the benefit risk profile and the different outcomes for A and B. What's your view?
Yeah, so we talked a little bit about the expectations already, and now you sort of bring up differences between A and B, and um, so it reminds me that I didn't mention one of the important eligibility criteria, and which is different between the two, which is it is related to the package delivery and the fact that this uses AAV, which is a common virus that people can be exposed to, and so and can limit the efficacy of the treatment, particularly for hemophilia A. And so people do, particularly with hemophilia A, have to be screened to see if they've had immune response uh, to this virus, and if they do have high levels of immune response, then are not eligible, and that's different than for hemophilia B. So just wanted to put that in there. But then, I think for the hemophilia B uh, therapy, um, we've seen um, I think less variability in terms of factor response and more sustained expression from data that we have so far. I think for hemophilia A, we're still seeing excellent response, but a little bit more variability and some decrease over time. But what, I think in terms of managing the expectations, thinking about the outcomes. So there's the factor expression, of course, as the main one, and then the impact on the ability to stop prophylaxis. So still, in both hemophilia A and B, vast majority of people have been able to stop prophylaxis and continue off, although some cases where need to go back on. And then and then of course impact on bleeding and how that translates to quality of life. And so as one of the things in the WFH shared decision making tool is you start with the background, and then you go into hemophilia A, you get that information, if that's your type of hemophilia, or you go into hemophilia B if that's your type. The other thing that we talked a little bit about then is that liver health. And so, as the gene therapy is directed to the liver, you can have liver enzyme elevation, um, which then, if your liver is inflamed, then there's risk that it will stop making the factor. And so the strategy then is to suppress that immune reaction, most often with corticosteroids, which can have their own set of side effects. So people need to be aware of this possibility and what the treatment is, and how long that might be expected. And then that goes to also difference between hemophilia A and hemophilia B, where those reactions and need for treatment are more common.
And just on that point for a moment, Courtney,
Yeah.
I think I think sometimes patients are confused by this because they think, okay, so I might need to take steroids because of the impact on the liver, and they start worrying about the gene therapy causing liver disease. But in fact, it's fairly normal liver inflammation, which is not surprising given the fact that you're sending trillions of viral particles to the liver. The liver gets a little bit inflamed. That doesn't really cause any concern to a hepatologist, but it's the
Yeah,
problem is that that inflammation, if it's missed, can actually knock out the gene therapy, right? So that's
right.
why you have to have these regular liver enzyme tests to make sure that the small bit of liver inflammation which may occur does not mean you lose the gene therapy.
Right. No, that's a great clarification because we don't want people then, as we start to talk about the liver and inflammation, then to immediately jump to the conclusion that they could have liver failure and need, liver transplant or, anything that goes along with that. So great.
Yeah,
Um,
I know at a recent conference, one of the hepatologists speaking about this said that the kind of liver enzyme um, increases you see in gene therapy, they wouldn't get out of bed for these. No, I think it's probably hard to get a hepatologist out of bed in any case. But yeah, I think it's an interesting point. Um, just on the difference between A and B, I think when we talk about hemophilia gene therapy generally, I think it can be quite complex and confusing for
yeah,
people. Now, if we separate it into A and B, and of course, when you're doing shared decision making, if you've got a hemophilia A patient in front of you, he doesn't need to know about B and vice versa. So it actually
right.
becomes simpler, right? There are
Yeah,
differences. As you say, the hemophilia B gene therapy seems to be more durable from what we could tell from data up to now,
yeah,
less variability. Um, uh, More predictability in terms of the number of people who didn't respond as lower, but also a significantly lower proportion requiring steroids for a shorter period of time. So I think if you're talking to somebody with hemophilia A and are considering gene therapy, they almost have to assume they'll probably require steroids. With B, it's they might require steroids.
yeah.
Would you agree?
Yes, yeah. And I think that's right. I mean, you want to, focus on what is applicable, to that specific patient that also relates to what the comparators are, which there are similarities and differences. I put the caveat that it is maybe important to just acknowledge that there are these differences and that the people should um focus on what's applicable to them. For example, when I've been introducing the factor 8 mimetic emicizumab to families and go through the efficacy, safety, all the how it's given, and most of the patients do not have factor 8 inhibitors, but I point out that if they go to the prescribing information and they see this black box warning about thrombotic risk, that is not applicable to them, or if they do have factor VIII inhibitor, how we would mitigate that. So I like to point out because I don't know if someone's going to go online and then see something that's sort of related but not actually applicable to them.
Right, but I think if you can separate the A and B with the
Yeah.
patient in front of you, it's a much easier series of conversations, right?
Yes, exactly.
And I think when we talk about expectations as well, and we look at the outcomes, regulators have always looked at annual bleed rate as the core outcome for most clinical trials. But in fact, that's a very it's not a great outcome in the sense that is it a bleed or is it not a bleed? Who decides if
Yeah.
it's a bleed? Is it the patient or is it the doctor? Does the patient need to come in, get an ultrasound? Is there blood in the joint or not? And ABR is very subjective. And I think with the core heme process, they looked at ABR, which just about made it into the top six. Chronic impact on chronic pain, impact on mental health. Um, they looked at the factor expression, and they looked at durability, and they looked at the cost. But certainly, many of us in the community feel that the most important outcome is factor expression achieved, because, as you pointed out, you'd like to be able to stop prophylaxis. So that depends on the factor expression
Hmm.
you achieve, the impact on your joints. If you're going to see a benefit in terms of less joint pain, maybe less subclinical bleeding, it's probably linked as well to the factor expression achieved. So I think that's a core outcome is the factor expression achieved, and of course durability as well.
Yeah, no, I think that's a great point. And no, I think about annual bleed rate, and now, with pretty much all of the studies, if they're involving prophylaxis, it's like median of 0. And so, like, that it's less impactful. And so, I agree. And as I've talked to some, men with hemophilia, um, they've said they do have different expectations. So some have said, yes, it's any expression where I can stop prophylaxis, that's great. And others who said, I don't want to be mild, I want to be normal, and I don't want to be like carrier status. And so I agree with that factor expression. And then you mentioned some of the other outcomes, and sort of what do you think patients can expect in terms of impact on quality of life, mental health, both maybe positive and possibly uh, negative, or something they might not expect.
Yeah, that's fascinating because if you look at the mental health impact, first of all, um, prior to the gene therapy trials, if you want to see if somebody's mental health is improved, surely you need a baseline measure. There was no baseline measure.
Yeah.
So, are you happier now than you were 3 years ago? I can't remember how happy I was 3 years ago. So, there's now a core heme mental health tool which can be used by the centres to actually establish a baseline at least beforehand. And I think then in talking to the patient about their expectations, what they want from gene therapy, I think mental health is important. And it's maybe a reduction in anxiety and depression, maybe a reduced bleeding rate, or stopping prophylaxis means they're having to spend less time thinking about dealing with their hemophilia on a day-to-day basis. And maybe somebody's mentioned to me the ability to be spontaneous, which I think is a
Mm.
good point. You know, um, I want to go to the gym. I want to go to this place. I want to do this activity today. Oh, I should have taken my prophylaxis this morning. I do it tomorrow. So you can be more spontaneous in a situation where you might have a decent factor expression, um, and I think also for younger men, they will want to look at things like travel options, career
Hmm.
options, which might open up to them if they have a fairly decent factor expression which is sustained for a significant period of time. And I think the you mentioned negative as well. And I was quite fascinated when I saw the first anecdotal reports of people who felt a loss of identity after gene therapy, and felt that hemophilia was very much part of who they are and what they are, and that was reduced by gene therapy. That surprised me, frankly, because the person still has hemophilia genetically. If they
Hmm.
have a daughter after having gene therapy, their daughter will still be a carrier. So the hemophilia isn't gone. It's just they're potentially changing their bleeding phenotype and their hemophilia type very significantly. But I accept that, and some people do feel a loss of identity. I wonder personally if it's because some of them now feel they can no longer participate in activities with their colleagues with hemophilia, with their patient organizations, with
Hmm.
their chapters. Um, and I think also that there may be a case where you were attributing every problem in your life to your hemophilia,
Hmm.
and then you get gene therapy, you get a significant factor expression, and suddenly you realize some of the problems are still there, and in fact
Uh,
they had little or nothing to do with hemophilia.
yeah.
I was talking to somebody by WhatsApp 2 weeks ago who had gene therapy, and he was saying he's much more physically active since having gene therapy, and he was playing tennis, and he got a tennis injury to his elbow. And it wasn't a bleed; it was not hemophilia related, and he was quite annoyed that he could get normal injuries. So
Yeah.
you know, it
Yeah.
doesn't solve the other problems in your life, perhaps.
Yes. Yes. I mean, I have, it's great, if it, allows people to be, more physically fit and try new things they might not have ever imagined. But then I think that, our physical therapists in the center are still very important in terms of helping people know how to, do sport safely, and what, how to train, and how, to minimize injury, and then still how to recover. So
No, I agree. We saw
yeah.
some of this with a switch over to emicizumab, where
Hmm.
some of the patients were getting very much more physically active, and some of them were actually getting bleeds because they weren't doing that physical activity correctly, or they weren't training or warming up or cooling down correctly. So I think it's a learning process.
Yeah.
If you've grown up with severe hemophilia and you've been told not to do activity A, B, C, or D, and you can now do A, B, and C, you have to learn how to do those properly.
Yeah. Yeah. I was wondering if we might talk about then if as I said, like, majority of people are responding, but, how to talk about and manage expectations if there isn't a response or if there is loss of response over time and what the options are. Because certainly that could be a concern if someone thinks, oh, if I don't respond, then like I have no treatment options. Uh,
Well, I think the first thing to make quite clear is that your previous treatment options are still available to you. So if you've been on factor concentrate or emicizumab and you don't get a response to gene therapy, or your response fades or goes away, you can go back to your previous therapy. And obviously, if you get bleeds or you need a higher factor level for surgery or for a major trauma, you can still get factor. You can go back on prophylaxis with emicizumab if required, or factor. So I think the previous options have not gone away. They're still there. It's not like you develop an inhibitor to your previous treatment. So that's a really important
yeah.
point to make. But I think it is very important to manage expectations around factor expression and durability. And we would say to people, look, if you look at factor 9 gene therapy, it looks like the durability may well be at least 10 years. And the mean factor expression is about 35% after 2 or 3 years. Okay, but you don't want somebody thinking, right, I'm going to get at least 10 years and I'm going to be at 35%, because that's a mean. And we don't want them focusing just on the mean. So you need to look at the range. So the person has to be prepared for, what would I like? Would I like at least 10 years? Would I take a gene therapy if it was only 5 years? Would I want at least 10 years? Would I want a factor expression of at least 50%? Do I want 100%? Do I want at least 10%? And the crucial thing in my mind is that they have to figure out what they would like, what their optimal outcome is, but they must be prepared for a range of other outcomes. And if they're not prepared for the range of other outcomes, then they're not ready for gene therapy, because you can't say, oh, can you give me a dose, please, Courtney, that gives me 11 years at least and a 50% factor level, and you calibrate the dose. That's not possible. So they must be prepared for, yeah, I'd like 50%, I'd like at least 10 years, but I'm prepared if I get 5 years, I'm prepared if I get 3 years, I'm prepared if I get 5%, I'm prepared if I get 150%. So it's getting people ready for that. And that's new in hemophilia,
Yeah.
because that's never been the case with factor concentrates or with the mimetic. You can calibrate the dose, you can change the dose, you can change the frequency, you can change the treatment. You can't do that with gene therapy. So I think that it's a one-off treatment. You hope you have these expectations that you're hoping for, but if you must be ready for the range of expectations that you can get. And I think, in fairness, the companies now, with the two licensed gene therapies, they have started producing these pie charts which show the percentage of patients in the phase 3 trials who achieved each factor expression level. And that's
Hmm.
important, because I don't want patients focusing just on the median. They need to look at what what's my what's my percentage chance of being in the normal range, or between
Yeah.
15 and 30, or 15 and 40, or 5 and 15. And the pie charts are useful for that.
Yeah. Yeah, and I think, so certainly some people won't be prepared now or won't, feel like that's the right choice, but we're really trying to get the longer term data, I think both from the companies and then through the organizations collecting long-term follow-up. And so hopefully then, in another 10 years, we'll have even more data that for people to make informed decisions on. But do you want to talk about sort of the registries and
Well, yeah,
importance?
I mean, I think that the World Federation, in collaboration with IST8 and other organizations, have started the Global Gene Therapy Registry. I think that's really important, because these are going to be rare therapies. There won't be enormous numbers, and if you want to look at any rare adverse events or rare outcomes, you need to collect data globally on that. And this is something we've needed for years on inhibitors, for example, and was never done. Everybody collects their own data on inhibitors. We've never had a global inhibitor registry, which might actually provide some answers. So I think starting off now with gene therapy, just being licensed the last year, it's crucial that we have a global registry, that all the data is in there, because otherwise you will miss adverse events that are very rare. You will miss trends. You will miss patterns. So I think that those registries are very, very useful. And indeed, we have a significant number of patients who would say to me, "Oh, I'm interested in gene therapy, but not quite yet. I'm going to leave it a couple of years and see how it goes, what the real world evidence is like. And that's a reasonable attitude to take as well. As you said earlier, there will be people who will want gene therapy straight away, the early adapters. There'll be people who absolutely don't want gene therapy. There'll be people who are very interested in gene therapy, but not right now, maybe wait a couple of years. And there'll be others who their interest will develop depending on what the outcomes show over the next 3 or 4 years.
Sure.
So I think it's all the registries are crucial.
Yeah. Yeah, and I'd just like to remind people they can put questions in the comments or chat. I was going to follow up though and say that perhaps this, the longer term data may also influence insurance coverage and, and potentially eligibility. And so I think, yeah, we sort of left the elephant in the room till about the about the end, but
Well,
yeah.
yeah, I mean, I think insurance coverage. I don't fully understand the American healthcare system. I've never met anybody who does, but I think the ICER economic evaluation of gene therapy, which was carried out last year, and I took part in that, was a very good process, very clear, very transparent, very good process in itself. What was unusual for a European was seeing the American prices. So when they look at the list price of the two licensed gene therapies in the USA, 3.5 million for Hemogenics, about 2.5 million for Roctavian. That seems incredibly high to a European, but that equates to about 5 years treatment cost in the USA. So if you look at it that way, it's slightly different. I think the American healthcare system is entirely different to any other country. It's very very complex, and it may well be one of the few countries where they will look at a one-off payment model for the gene therapy. I think in many other countries, a one-off payment model won't be looked at. First of all, because even if it was cost-effective, um, it the budget impact would be enormous. So that would mean that either they won't reimburse it, or else it would mean you could treat a very small number of patients every year. And then if you're limited to a couple of patients each year and you have more patients who want this, how do you fairly select them? And I think the second thing is that payers will be very nervous about paying a one-off payment for a therapy which there's still a degree of uncertainty about outcomes. So they'll want to manage that risk of uncertainty. They'll want some risk-sharing payment models. So I think the most likely model for many countries, and certainly many European countries, is an outcome-based annual payment model over a number of years.
Mm,
That has the advantage that if the gene therapy is working very well, you pay the agreed cost. If it stops working as well, you might lower the payment. And if it stops working entirely, you stop the payment. It would possibly, you define the outcomes very clearly. You define the term of payment very clearly. And that also means that the budget impact will be minimized. And hemophilia gene therapy is different to gene therapies for other conditions like spinal muscular atrophy, which is a horrible disease in early childhood, and they don't really have any other therapeutic options. So if a parent whose child has SMA is offered gene therapy, they will look at that very very positively, but probably difficult to get it because of the cost. Whereas in
mm,
hemophilia, we have other treatment options, but we have the advantage of having an existing budget stream in most
mm,
countries. And most healthcare systems don't like new spending. So the fact is that we have an
mm,
existing budget stream for prophylaxis. So you're not saying we want this very expensive therapy on top of the current treatment cost. We're saying this should replace the current treatment cost. But of course, if it doesn't replace the current treatment cost, then that has to be built into the payment model, because if the individual has to go back on prophylaxis or has to take significant quantities of factor concentrate or emicizumab post gene therapy, then that I would expect to be part of the payment model in most countries.
yeah. No, thank you for sharing your expertise on that. And as you said, yeah, I don't understand the American healthcare system. And, but, talking at least, within our hemophilia region, on the West Coast, there's even different models in terms of if it's going to be the institution, sort of university institution or individual treatment center who's going to purchase the product, uh, and even what, you know, uh, how that will work. And then, there's also discussion just in terms of if it's one center who does everything, so that they have the discussions with the patient, they order the product, they give the product, they do all the long-term follow-up, versus having more the spoken hub model where there may be referrals into a center, and then they do maybe the counseling and the dosing, and then transfer the back to the primary center. So that certainly impacts payment models, or making sure that there is the support within the treatment center to be able to do the different aspects that it's responsible for.
No, I agree, and I think in Europe it's going to be somewhat simpler. It may take quite a while to get agreements in place, but in many European countries, governments provide the healthcare. So therefore, you're actually dealing with a smaller number of bodies. Now, the agreements
Mm,
might take slightly longer, but you're doing the whole country. And secondly, there is an agreed hub and spoke model in Europe, and I think it's recognized that you go to a hub or expert center for usually for dosing and for the initial consultations and the expert evaluations and shared decision making. But then your local centre would do the routine follow up. It's not realistic to expect somebody to travel several hours twice, every week for liver function tests for a factor level, where these tests can be easily carried out in a local centre.
yeah,
But the crucial part there will be communication between the local centre and the hub centre, and making sure that people don't slip between the cracks. I think the
yeah,
nightmare scenario is somebody having a routine liver enzyme test done and by the spoke center, and the liver enzymes have been slightly elevated, and they think the hub center is communicating, and the hub center thinks the spoke, it ends up as missed. So I think the hub and spoke center itself, a concept which is very good, needs very, very clear copper tight um, communication protocols to make them work.
yeah. I agree. And I think that brings up the point that really the whole multidisciplinary team needs to be educated in gene therapy. And so, in particularly the nurses, who are
Mm.
often, primary point of contact for coordinating visits, receiving lab results, getting them to the physician or other practitioner. And so, and this is totally different, in terms of, or at least somewhat different. In we get factor levels, we do PK studies, we do inhibitor testing, which I think in the young ones, that's like the really crucial piece. We wouldn't want to miss a new inhibitor, but it's different. It's going to change the workflow to some degree in the clinics, and so we really need to make sure that everybody involved in the process is educated and really understands the importance of tracking the results and being able to act quickly on
I
them.
agree. We're talking about optimal management of adverse events which may occur, and making sure that they don't destroy the potentially beneficial impact of the gene
Yeah,
therapy.
yeah,
And then if we look at long-term monitoring, I mean, this is another difference, I think, for people with hemophilia. There's quite a long list of visits in year one, the sporadic visits in year two and three, and so on, a couple of times a year. Some people have said to me, actually, well, if you have gene therapy, I should be able to stop going to the center altogether after maybe the first year. I think that's not just wrong; it would be foolish. I
yeah,
think people have developed long-term relationships with the hemophilia center, and even if whatever factor expression you get, you want that checked at minimum once, twice a year to make sure that factor level is being maintained. You don't want somebody going around assuming they have a much higher factor expression than they have and living their life accordingly.
yeah. And yeah, I was just thinking too, I mean, probably particularly in the US, people move around. And so we'll certainly need to have systems in place for patients to transfer from one center to the other, and making sure that if the center they're going to has the same expertise, and uh, and then and the history too of that person and their response and side effects.
And of course, if you're looking at outcome-based payment models, you absolutely have to kind of track
Yes.
the person and keep an eye on the factor level, because otherwise you may not be able to fulfill the requirements of a contract for an outcome-based payment model.
Yes. Yes, I
What about?
imagine. I was
Sorry,
just
go
gonna say
ahead.
we could have, yeah, probably a 3 hour long conversation on the nuances of the insurance, but let's move to the next topic.
Yeah. What about long-term monitoring? Do you see any
Yeah.
difficulties with that?
Yeah, so I think it is. I mean, I think it's the education up front in terms of to ensure that success and adherence with the treatment, because I think it's like regular chronic treatment with medications that if you started and you're having a certain symptom, and then you are take your treatment and then the symptom goes away, then sometimes you need reminders of why you're taking that treatment, so until you miss the dose and then you're back to square one. And so I think we need some um, process in place in terms of ensuring adherence with the follow-up, because the goal is for people to be feeling great, for for not having to rely on the healthcare system and regular treatments. And uh, but as we've talked about, the follow-up is critically important, because otherwise, if again a liver enzyme elevation is missed, then they could lose response, and then yeah, be back to square one. And then two, just the importance for knowing really how long term this works, so that can inform, okay, how can gene therapy be improved? We're sort of in version one, right, at
Mm.
this point, but then also offering that information to people who aren't sure based on the current amount of data.
I agree. I think individuals who are currently taking gene therapy, and maybe the first couple of hundred or thousand who take a licensed gene therapy, they have an altruistic responsibility to the rest of
Mhm.
the community to get this data collected so we can make proper decisions as a global community as time goes on. But even from a purely selfish point of view, it's in their own best interest
Yeah.
to be properly monitored, because as you say, um, they may lose factor expression, they may require steroids, they may have other adverse events that are theoretically possible that they want to be screened for to make sure they don't occur. So I think long-term monitoring is absolutely vital. You're not going to after the year one, they're not going to be tied to the center very, very often.
Yeah.
Probably once or twice a year maximum. But that visit will be important. And as you say, if they move to another part of the states, another part of the world, in the EU, you can also move between 27 countries. There's
Yeah.
freedom of
Right.
movement. Then you need to, somebody in Ireland can move to Germany or Bulgaria and
Yeah.
live there. You'd need to link in with the center there and make sure you're getting the basic blood test done. And the basic blood tests, I suppose, are the factor level and liver enzymes. They're very easy to
Yeah.
measure. These are not complex, specialized tests. So it's not that the person is going to a country where they won't be able to do these monitoring tests. Every hemophilia center will be able to do those tests. But I think it's really important that people understand that you still need to keep a minimal contact, at least in the long term, with your hemophilia centers.
Yeah. And I agree that in where we live, these tests are very easy. And we just have a few minutes left, but just thinking more globally, I know there are some efforts really to reach the world with gene therapy, uh, and but there'll be need to be new infrastructure there. I think even with, I mean, the first thing, diagnosis, but then in terms of how to implement and follow up in under-resourced countries.
No, I agree. And I think if you look at the current environment, I find it difficult to see much penetration of the current generation of hemophilia gene therapy into low or medium income countries because of the cost, and the cost of goods, and the cost of production. Having said that, I think there are several countries, including India, where they're currently doing lentiviral gene therapy clinical trials. And also, even if you could use the AAV gene therapies in India, China, and South Africa, up to 90% of the population have pre-existing antibodies. So you certainly couldn't use the hemophilia A gene therapy. You might be able to use the B. But I think gene therapy, as time goes on and it gets less complex to produce and manufacture, and countries start producing their own gene therapies, we may be able to see gene therapy being produced in upper or middle income countries, at least at an affordable cost for those countries. And also, I would hope that as gene therapy and the newer therapies gain more market share in the high income countries, that in turn leads to a decrease in the price of the current therapies for many of the countries who currently have no therapy. So if you're in sub-Saharan Africa, or you're in Bolivia, or you're in rural India, you don't necessarily need gene therapy. You need access to treatment that will allow you to ameliorate the worst impact of bleeding, and that can be factor concentrate. It doesn't need to be the latest generation of treatment, but maybe gene therapy and these new developments will help to change the economic environment for those other therapies so they become more affordable. And in fact, we've seen this in a number of countries over recent years, where they are now buying factor concentrates at a fraction of the cost that they were being offered those many years ago, which is a good place to be. Um, I think just in terms of advocacy and support group access and resources, I think there's a lot of work going into this. The ISTH, WFH, NHF, EHC, the Canadian Hemophilia Society have all produced very good patient materials and clinical materials on gene therapy. And actually, one of the companies is now producing almost a compendium, a list of all of the resources out there, which will be publicly available. And that's going to be really
Oh, great.
important. You don't need to produce new material yourself, you
Yeah.
just need to know where to go to get it.
Yeah. No, that's a great point. And I actually gave a talk at a family education event this weekend, and it wasn't specific on gene therapy, but just raising awareness that there's all these organizations, all these resources, depending on how you like to learn. You can, read printed or online materials. You can watch a video. You can listen to webinar or podcasts. So I think, it brings us back to shared decision making and, you know, setting, the first step in terms of getting the education. And with that, being mindful of for that individual what the choices are, how the person likes to learn, what are, health literacy and, even cultural considerations, who the key stakeholders are that, should be involved in the discussion. So it's great that all these organizations are so committed to to the education, and
No, I
hopefully,
agree. I agree, Courtney, because there's no point in producing a very nice, glossy, beautifully illustrated booklet and give it to somebody who gets all their information from social media.
yeah,
So we have to produce the information in the media that people use, whether it's booklets or social media or videos or infographics or podcasts or webinars. And the thing is, no one of our organizations can produce all of these. So why on earth should we kind of reinvent the wheel?
yeah,
We should borrow and take from each other. And frankly, hemophilia patient organizations have done this for years. If I want to do a new booklet on, say, mild hemophilia, the first thing I do is a horizon scan. I'll see who else has one, and
yeah,
then I get permission to use as much of that as I can do.
yeah, yeah. So, well, we've had a great hour. It's gone really quickly. And, we talked about shared decision making. We've talked about, what gene therapy is, how it's given, eligibility, what's important outcomes wise and safety wise, and, insurance. So, we've talked about a lot. And, but I like to thank everybody for being here today, and to make sure to mark the calendars and join us for session 2 on Thursday, November 16th, where we'll continue the conversation on navigating conversations about gene therapy along patients with hemophilia and their families. Discussion topics will include eligibility, risks, access, benefits, administration, and monitoring, going more into what we've talked about today, and certainly having availability for comments and questions. But Brian, it's been a pleasure to talk with you. Any final thought or?
No, great
Mm,
talking to you, Courtney. I'd just say that anybody who's listening to this recording, if they have any questions after today's recording, please feel free to send them in the next day on November 16th, and we can answer them after the second webinar as well. Great talking to you.
yeah, great talking to you too. Thanks, Brian.
Bye bye.
Bye.